Hello, everyone, and thank you for joining Advize Health for our webinar today on prepayment and postpayment reviews. I'm your host, Brittany Hurd, and I'm pleased to welcome you to today's event. Before we get started, I wanted to give you a little bit of background about Advize Health. At Advize Health, we analyze processes, create protocols, and implement solutions for healthcare entities of all sizes. Advize Health has been in existence for more than 12 years and employs more than 60 of the industry's top experts nationwide. Advize does not subcontract employees, so you can rest assured that your needs are addressed by someone that is specifically assigned to your organization. We offer many services, including healthcare compliance analysis, medical documentation auditing services, and educational opportunities for numerous topics such as ICD-10 training and clinical documentation improvement. Our priority and promise to the healthcare community is to always tailor our services to our clients' individual needs and provide cost-efficient services that every entity is able to afford. Our speaker for today's webinar is one of Advize Health's medical auditors, Melissa Jewett. Melissa is a certified professional coder with AAPC and a certified professional medical auditor. Today, she'll be focusing on the procedure, rationale, and historical context of pre- and post-pay audit programs, the associated CPT codes, and the strategies for investigation and recovery. Melissa will start off going over today's agenda. At the end of the presentation, we'll also have time for Q&A. Some housekeeping items related to the Q&A. If you have questions throughout the webinar, please be sure to submit them via the questions or chat text box in the GoToWebinar interface and send them to all organizers, and I'll make sure that Melissa has time to answer them at the end of her presentation. Also expect to receive an email which includes a certificate of completion showing the 1.5 CEUs you've earned, a copy of the presentation, and a recording of the webinar within 2 to 3 business days. I'll now turn it over to Melissa, who's going to begin the presentation on prepayment and postpayment reviews.
Thank you, Brittany. The agenda today, we're going to go over and provide a comparison of audit types, an outline of factors that may influence the audit type selection. We'll review the audit process and expected outcomes, and then we'll have our question and answer and best practice discussion. To start off, we'll do a comparison of post-payment versus prepayment audit. So who audits medical records? Insurance plans, commercial, federal, self-administered, providers as a self-audit, or hospitals as a self-audit. What is the audit purpose? For program integrity, protecting the plan's funds, patient protection, quality of care, and provider education. So the common audit types that we often deal with are either post-payment, prepayment, or self-audit. The value in choosing the best type of audit lends itself to multiple factors. When selecting the appropriate audit type, first answer these questions. What is the purpose? Is the audit for education? Is there overpayment recovery? Or both? Are there any trends? And how long has the pattern been occurring? Has a provider ever been audited before? Has the provider ever been excluded from the federal type plan? Or is there any other concern for fraud, such as patient complaints of services never being rendered? Is extrapolation and/or recovery authorized? In discussing post-payment versus prepayment, we see that plans often choose to utilize both post-pay and prepayment audit approaches, and we see that they deploy a post-pay review often first to capture the abundance of errors that may have occurred over long periods of time, and then follow up with a prepayment review period to promote provider education, as well as to gauge the provider's corrective actions. Now just to go into post-payment a little more in detail. For post-payment audits, these audits occur after the insurance plan has made payment for billed services. These audits have a look-back period, which cover a wide range of dates. Oftentimes, you'll see a look-back period that covers 1 to 2 years worth of data. Post-payment audits are deployed after data analytics identifies aberrant or questionable billing patterns. Patterns are identified by comparing providers to their peers. Audit locations. So we can audit on-site, which allows the auditor to visit the healthcare provider. And often in this situation, you have opportunity to perform interviews as well as view the records on-site. Or a desk audit, and the provider in this situation would submit the records, typically by secure upload or by certified mail, to the auditor's office. In a desk audit, the review is completed, at the auditor's desk. So here's an overview of a post-payment process. And so for post-payment audit, excuse me. First, we take a look at the claims universe. The population is identified. A claims universe with a specified date range for a provider group is selected. And next, we have to find the sample. The sample of claims from the claims universe is selected. The sample size does vary and is typically determined by a statistician or another source such as RadStats. Audit review. The sample claims are reviewed by the auditors to determine if the claims were paid correctly, and overpayments are projected. The sample claim errors are projected over the total claims universe, the population, which determines the total extrapolation amount. Here's some more definitions or terms that have to do with sampling. We often talk about simple random samples, and a simple random sample is a subset of a statistical population in which each item in the subset has an equal probability of being chosen. In lay terms, for example, if 20 people put their name in a hat and 5 names are drawn from the hat randomly, all 20 people had an equal chance of being selected. We have stratified sampling. This is a sampling method where the investigator divides the population into separate groups called strata, and then pulls a probability sample, often a simple random sample from each group, as well as statistical sampling. Defined by the Medicare Program Integrity Manual, the purpose of statistical sampling is that it is used to calculate and project the extrapolation or the overpayment amounts on claims. So when we're looking at post-payment audits, we often come across a number of errors, and this is a list of common findings that we often find when we go through these audits. So commonly, we will find insufficient documentation. That is, it could be anything that's missing, such as missing records, missing pages, no signature, no counter signature, missing elements such as E&M, the evaluation and management key components, are undocumented, or there may be other conflicts in the documentation that makes it insufficient. We also come across not medically necessary services. And not every audit has the auditor determine medical necessity. That would be defined within the scope of the audit to begin with. But if the audit focus is for medical necessity services, then the auditor will apply the medical policy. And a lot of times these audits utilize a nurse or a physician to review. Unbundling, we come across this as an error often. Determining the inappropriate use of modifiers, which allowed for payment of an unbundled and not separately supported CPT code. Auditors utilize the NCCI edits when looking at these items. Another error we come across is part of the global fee. So this is a situation where the provider is billing outside of the CPT designated global fee. For example, the maternity global package. Improper procedure codes billed or incorrect coding is another common error we identify. And this also could include situations where providers are using code substitution. So oftentimes practices become familiar with what codes are payable and what codes are not payable, and they may choose to substitute a code that they know is not payable by the plan and bill a code that they know is payable. So that is considered improper procedure coding, incorrect coding. Services not performed. This, obviously, if you can determine this in the record, there is something that may be harder to determine in the record that the service was actually not performed. It may take additional investigative actions to determine. But this definitely, if you were to determine that the service was not performed, is an indicator for potential fraud. And we have seen this. We have actually seen this recently with dental. And the dental claims are the providers will submit radiographs that were taken before the treatment was done, and the radiographs that were taken, months after the treatment was done. And so the provider can see, or the reviewer, the auditor, can see that the service that they billed was actually never done by looking at those radiographs. We also come across duplicate claims. Duplicate claims is really not a major error as long as it's just an error and not an abusive action on the provider's part. But so it does afford a recoupment if it was a duplicate paid claim. And there may be other instances where it could be multiple billing providers billing the same service, same date, that type of thing. Incorrect billing providers. We've come across this often where the provider is not eligible to bill under the tax ID or NPI number that they submitted the claim under. Often this occurs with physicians billing under another physician's ID. And many states have different rules on that, but commonly the rule is another physician should not bill under another physician's ID. Of course, each plan has their own rule as well as the state guidance, but this is something that we do find often. And overutilization of services. So services that are performed too soon or at an abusive rate. Oftentimes, again, back to the dental example, certain services have a utilization schedule. So the patient could have a certain type of radiograph done every 6 months or once every 3 years. And when we get looking at the records and the data of claims paid, we see that the services were performed too soon or at an abusive rate. And this finding may also lead to quality of care type referrals, where in the example again with the radiographs, there was concern for too much radiation. The patients were receiving radiographs every time they went to the office, and it was unnecessary and it was too much radiation. An item to be considered when you're looking at post-payment audits is extrapolation. Extrapolation is a powerful tool unique to statistical sampling and post-payment reviews. This process statistically identifies the provider's total liability based on the errors identified within the sample claims. Extrapolation is not for everyone, but utilized widely. Federal plans support extrapolation for the Medicare Prescription Drug Improvement and Modernization Act of 2003. States determine regulation of extrapolation. For example, we've worked in California, which extrapolates. Hawaii, there is no extrapolation. Nevada, there is no extrapolation. And Washington, there is extrapolation. So it's a 5-state choice whether to extrapolate, and then it comes down to the plan level as well. Commercial and self-funded plans choose whether or not to extrapolate, giving special consideration for provider abrasion. So that's always an issue that's in the forefront for plans, is how badly do they want to, affect their provider. And state regulations always is a consideration. And then there's the concern that when you extrapolate, legal counsel will become involved at some point likely. So for post-payment reviews, often the focus or the audit type involves reviewing high-level evaluation and management claims like level 4s and 5s, as well as modifier 25 and 59. We commonly review behavioral health claims, dental services. That's a hot topic that's been on the OIG hit list recently and something that we've had a lot of experience in lately. DME as well, the same there. Home health and skilled nursing, ambulance, surgical, outpatient hospital, ICD-10, and risk adjustment. And these are just a few suggestions for post-payment reviews, common ones that we see a lot, but really anything could be audited if you've trended it. So to break down a high-level E&M audit, this audit focuses on levels 4 and 5. The review includes confirming the documentation supports the level build. The review takes into consideration documentation integrity issues, such as cut and paste, conflicts that may be in the HBI and or the exam. And these audits are scored utilizing the documentation guidelines, CPT rules, as well as a plan-specific guidance or policy. So if you take a minute and look at this graph, I know it's small, but you'll notice that this is a graph and it was pulled from the OIG, and it ranges from the years 2001 through 2010. And each column, so these codes here, 99281 on the left, is the lowest level emergency room visit, and then it goes up to 99285 on the right. And so the years are spanned, again, 2001 on the left, all the way up to 2010 on the right for each code. So you'll notice here, by just looking and glancing at this graph, that over time, over this span of years, almost all of the 99281s and nearly all of the 99282 billings have disappeared. And if you really look at this graph, they've all dumped into the 99285 bucket, which is puzzling because a 99281 and a 99282 have very low medical decision making, low or straightforward, and a 99285 has high level, high risk decision making. So how did that happen, and why is that happening? So this is just a visual support for why high-level E&M audits should continue. We often review in post-payment reviews, we often look at modifier 25 and 59. These modifiers have a long documented history of abuse. Auditors often, we review the documentation and confirm appropriate application of the modifiers, specifically determining if separately identifiable services are supported. Many providers don't understand the appropriate use and globally apply these modifiers, which creates a unique situation. We have experienced situations where the modifiers are applied and it created a financial error, which means that the plan or the client paid the claim and they should not have paid the claim because the documentation did not support a separately identifiable service. And there's often times where it creates a non-financial error. So when the provider globally applies the modifiers, the claim, if there was no NCCI edit, and the claim would have paid no matter what, whether they put the modifier on there or not, that creates a non-financial error. We also take a look at Modifier 57 in post-payment reviews. Modifier 57 is applied when the provider makes a decision to perform a major surgery. So where often you'll find the little the issue or the billing error around Modifier 57 is that providers will see the patient, say they see him in their office, and they make the decision to perform major surgery. They schedule that visit, and that visit where they make the decision is billed with a Modifier 57. And then they get on the surgery schedule, and it goes out a couple weeks or whatever, maybe a month. And then the hospital most hospitals have, an internal protocol that all patients must have a pre-surgical H&P within 1 day of the surgery. So providers will often bring the patient in the day before surgery or maybe that morning and do an H&P. And then they bill that claim with a Modifier 57. So there's some techniques that plans could use to limit the usage of that modifier, maybe flag it if it's been billed twice within a period of time, or they could do post-payment review. And the reason that we suggest post-payment review for this modifier is because if this was considered for prepayment review, you may not have all of the necessary records, and the whole situation may have not played out at the time of reviewing that first claim. So we consider this a better option for post-payment review because the provider will have probably already saw the patient, performed the surgery, and all the billings and records would be available. We also suggest post-payment audits of procedures. We review the documentation to determine if the procedure billed is documented sufficiently, confirming that risks and benefits were reviewed and discussed, consents were signed, instrumentation, what technique, what was a scope used, was a scalpel used, was it debrided, was it excised, the instrumentation and the technique of the procedure is documented, and the finding. What did they find when they went in there and did the procedure? What was the treatment and the plan? Recently, we found on the CERT 2015 report that minor procedures have a very high error rate. CERT identified insufficient documentation as having an error 81% of the time in the records they reviewed. And we see that. We really see that to be true. Commonly, we see records where only the name of the minor procedure and the associated procedure code is documented. So, and we think that this has been common since the use of EHR. EHRs will just spit out a code, and then there's no elaboration from that. Was the procedure done? Was it performed? And how did it go? And how is it unique to that patient? Another post-payment scope that we often look at now is ICD-10. So we think that ICD-10 reviews is a good post-payment review, especially because it's a new thing for providers. So it's going to give your providers some time to develop their patterns, to develop their coding. They should have had time to practice all these years before implementation, but giving them this time is a good idea. So post-payment review of ICD-10 claims is probably a good thing. Another item too is there was a lot of concern and talk about ICD-10 implementation holding up financial flows. So post-payment review would be respectful of that as well. And risk adjustment. Risk adjustment is by virtue of post-payment review, as it is a scoring mechanism used based on paid claims and historical visits. Most commonly, this is referred to Medicare risk adjustment. And we also suggest that this could be a provider or a facility self-audit to ensure proper documentation practices. We find often that providers who maybe they participate with a managed Medicare plan, and they are having to follow rules for risk adjustment claims coding, that the documentation is kind of like one size fits all. Whether it is a fee-for-service claim or a risk-adjusted claim, there is no difference. And there would be a lot of error to doing a one-size-fits-all type documentation, because risk adjustment claims require providers to bill every diagnosis and to document every diagnosis the patient has had. And we all know for fee-for-service claims, going according to the documentation guidelines in CPT, the provider should be documenting what they're treating that day, what is pertinent, what is active, and of course they document the history, the patient's history, but it's not as part of the plan. It's a history item. And we also are suggesting a really interesting area for post-payment review is ambulance services. And so again, from the CERT 2015 report, the comprehensive error rate testing determined that 79.5% of ambulance claims reviewed were found to contain insufficient documentation. And a recent audit performed by CMS identified $30 million in overpayments for just the first 6 months of 2012. This audit yielded an interesting finding. So they coined the phrase mystery ambulance rides. Mystery ambulance rides is really kind of interesting. There's a few videos, there's a couple of news stories that promoted this. You can Google, look it up online, watch it on YouTube. But basically, investigators rode along and followed the ambulance service and came along and realized that people were taking ambulance trips to basically nowhere, or maybe somewhere, but definitely not a medical facility. Maybe they went out, maybe they had to go out for lunch or something. So that is what was the major finding with that CMS audit. So we suggest post-payment review to identify potential mystery ambulance rides, and this uses investigative techniques and data analytics, which look for situations where there was no corresponding or resultant medical service claim from either a hospital or a provider's office. A prepayment review would not be a good choice, as the hospital or other outpatient facility may not have billed for their service as quickly as the ambulance service did. So what you're doing is you're confirming that when a patient took an ambulance ride to a facility, the facility billed for a service on that day as well. So it connects the dots. For post-payment audits, sometimes post-payment audits have challenges And we've developed, some solutions to these challenges. Oftentimes, one of the challenges is getting clean data. Plans and products with differing rules sometimes can become an issue. For example, if you work with a carrier and they have multiple product lines, and maybe one of their products is a Medicare Advantage plan, the rules that pertain to the Medicare plan will probably and definitely most likely be different than the commercial, straight product plans that they offer. So having clean data that pulls out products that would have different rules is a challenge sometimes. And our solution is filter data to include or exclude certain products or liabilities, such as other party liability, and manage Medicare and Medicaid type plans. Or you would want to filter in the federal plans. It depends on your focus. As well as a challenge of requesting and obtaining records. Of course, that's definitely a challenge for post-payment review, requesting and obtaining the records. And the solution, that's kind of hardball. We're playing hardball with the provider, but if they're not going to comply, the bottom line is that it's a claim line error. If you don't send the record, it's denied. And that's unfortunate. Of course, providers have appeal time frames, and they have second chances. But if the claim is extrapolated, then it is unfortunate, that it's going to be extrapolated that way with an error. Medical policies and appropriate regulation application. So medical policies and regulations are hugely important. And every plan has their own policies, and every state has their own regulations. And of course, many are very similar, but at the same time different. So our solution is creation of a client to consultant living document. This is essential to address coding and documentation scenarios. This document is used as a coding auditor tool. And prior to the audit, we often suggest locating and determining all the applicable plan, state, and federal regulation policies. Another challenge of post-payment audits is the scrutiny that you may face from state-level associations. Plans are often pressured by large associations who also provide legal services to their providers. And it's good that they have a voice and they have a community to support them. And our solution is to work with them, hear their concerns, meet with them, listen to their, look at their policies, and just kind of work together as a team to eradicate the fraud, waste, and abuse, FWA. A few more challenges that we've identified with post-payment reviews is errors. So fraud, waste, and abuse occurring over extended periods of time. And, that's, I guess, the purpose of the post-pay review is to identify those errors that went over a long period of time. And administrative time and effort. Our solution to that is quality assurance and having open lines of communication. And the open lines of communication often is between auditor and the client, the client or the plan, as well as with the provider too. At some level, depending on your contract, you may have, as an auditor, have to discuss the audit results with the provider. So having open lines of communication is important there as well. Another challenge of post-payment reviews is provider abrasion. Providers often feel vulnerable. They feel like they're being attacked because they were put in the audit. And so what we feel is important from the auditor, from our consultant perspective, is that we offer valuable educational help in a respectful manner to the providers who are struggling to understand their audit results. And this is key. Yes, you find providers who are fraudulent and who are abusive, and you know, what they've done is not right. But generally, more often than not, we do deal with providers who just really didn't have the time to understand coding and didn't realize that they had to be the coder and don't have the funds to hire a professional coder, and you know, any number of excuses, but they do feel attacked. And so just dealing with the providers and being very respectful and allowing them a good educational opportunity. So for post-payment reviews, often we come across some, when we're looking at the records, we find trends. And a trend will surface very quickly when you're doing a post-payment review. Say you're looking at 50 records, 50 charts, likely you're going to see the same thing over and over. Like, people are creatures of habit. We do the same thing the same way every day because we don't want to forget to do something. So providers are the same. They want to document the same way. And you'll see it happen over and over and over again in the record. So addendums made to medical records. We see this a lot in our post-payment review when the review has come to the appeal stage. So it was audited and the results were sent out to the provider, and then the provider has an appeal opportunity where they could, for example, they could send in a record. Maybe there was a page missing, or maybe they forgot to send, you know, part of the record that was important, like lab results or something. But what we don't want to see is we don't want to see that they made a late entry to the record after they got the review results. And unfortunately, we do see that. So we do come across addendums that were made late. And one good thing about EHRs is, I believe it's a requirement, I think it's a federal requirement, that EHRs track all changes and updates made to the record with a date and time stamp. So sometimes, I shouldn't say sometimes, often the provider's making this late addendum and it's date and time stamping it, and so it shows that this was done like a year after the record was originally created. That's a big flag. So we notice the timeline. We take a look at that. We also compare the records. It's really important to keep that original record and do the side-by-side comparison of the record, and then when they appeal and they send records in again, compare them. What's different? Oftentimes you can track a situation like this when a provider is requesting an extension. They ask for an extension of time so that they can have more time to submit their medical records for the audit. And what is a timely entry? So that is a common topic, often discussed, and people look to CMS for definition there. And CMS states it has to be. It's a gray statement. I don't have it memorized off the top of my head, but it's kind of a gray statement that just basically says it has to be timely. But each state will define what is timely. For example, New Jersey defines a timely entry to the record is 30 days from the initiation of the visit. We also see other trends in documentation when we're reviewing things that were created in an EMR. And so this is an example of the CPT code list that I spoke to earlier, where the procedure code is just populated in there and then the name of the procedure. And so providers will often feel that this suffices as documentation. that they performed these services. But you know, there's a lot missing. You know, what was the, you know, what did they find when they did the service? Or, you know, what area, what site? So there's a lot missing there. Another trend we find is piecing together of documentation. EHRs pull forward from prior documentation. So pulling forward or cutting and pasting, it can really degrade from the integrity of the record. And sometimes auditors can clearly see this because the records are so disorganized. And you can also see this in this example here on this slide, where it shows different font sizes, and it throws, it's different formatting. This was all the same record, the same patient, same data service. And then you can also see this as an auditor where it'll repeat the exam will be repeated, or the review of systems will be repeated, and what you're reading is the default, and then you're reading what the provider added. And here's another example of that as well. Post-payment trends. We also see conflicts, again, that make the auditor question the integrity of the documentation. And this is, you know, a new thing with EHR. EHR has been around for a few years, and it's kind of giving us a new ball of wax, you know, something new to deal with. So often you will come across records that document, for example, in this example, the patient presents for congestion, fever, runny nose, times 3 days. The review of systems, constitutional, says no fever, no chills, no fatigue. And the ENT review is negative. The exam, ENT nasal mucosa is dry, no sinus pressure, pain on palpitation, and the plan is sinus infection, Z-Pak, and fluids. So the patient presents with HPI of fever, and the review of system says no fever. Now, is it possible that on the exam that the mucosa was dry and there was no pain or pressure? It's possible, sure, but being that the patient had a sinus infection, they probably would have pain, pressure, runny nose, or whatnot. So this is questionable documentation that the auditor should. This is like a red flag, you know, that there might be some integrity issues here. We also come across in post-payment reviews billing for time-based services when no time is documented, or billing for modalities like therapy modalities or chiropractic type services, and there's no documentation of in this example, the exercises performed, therapeutic exercises, and no documentation of what exercises were performed. We also come across another therapy, billing for manual therapy, when the service, the CMT service, which is chiropractic manipulation, when that's performed at the same site. So here's a situation where it would be an unbundling. And commonly we come across, even though most people are using electronic records, we still see some handwriting and unique abbreviations, which is not a good practice. And some states and plans may have rules against the use of non-standard abbreviations. But when we audit the record, we typically will request that the provider submit a key. If they use non-standard abbreviations, they can submit a key. But that would be an allowance decided by the plan. We commonly come across modifier 59 is applied when it's not needed. There's no NCCI edit, which I discussed earlier. And the same for modifier 25. And this brings us to prepayment audits. So prepayment audits, claim overpayment review and recovery processes are common to managed healthcare organizations. The process of a retrospective or post-payment review seeks to identify over and underpayments on claims, followed by a course of collection on overpayments and resolution of underpayments. Another approach to review claims for payment integrity prior to the actual payment, otherwise referred to prepayment claim review. So should we review it now or later? Essentially, prepayment and postpayment claim reviews require the same level of identification resources. However, as the prepay process identifies claim integrity issues, prior to payment, there is no need to conduct the process of recovery. Under the prepayment process, claims are paid at a much higher rate of accuracy the first time, saving all stakeholders considerable time, frustration, and expense. As a result of greater accuracy in payments and the absence of retrospective takebacks, providers gain a higher level of confidence in the organization's ability to pay accurately, creating a favorable provider relationship. So prepayment is often more favorable to the provider. Prepayment review offers the significant benefit of 100% recovery of potentially overpaid dollars with no recovery effort and associated cost. Here's the overview of what a prepayment audit looks like. A prepayment audit, first, we would need to determine the focus. This is often done by data analytics, looking at trends and outliers. Then the provider is selected. They're selected based on many different factors, but often in comparison to their peers. And another factor that would be considered is, was this provider already audited, maybe in a post-payment review, and how was their performance score? The next step would be notification to the audit group. The provider will receive a description of the audit focus, why and how they were selected, and how to comply. For example, sending in the medical records. The providers often will also be given kind of an idea of how the process will go and what they can expect. Claims then will be reviewed by the carrier in the prepayment review. The claims may be put into a pending or suspended queue while the prepayment review is completed. So the process. The process starts with the analytics, which represents statistical techniques that use historical data to predict future behaviors. Predictive modeling and analytics captures billing and payment detail from past claims data and uses the information to predict the future behaviors. In healthcare, anti-fraud, waste and abuse, and error rate efforts, it means scoring claims on the likelihood that they are improper. Used prepayment to identify suspect claims to stop review, or postpayment to identify claims to review for possible recovery. And these can include the billing frequency of CPT codes and modifiers in comparison to other providers of the same specialty. Again, that peer review, the peer analytic. Here is a graph that goes over some provider factors, patient-specific factors, and claim-specific factors commonly used when you're doing predictive modeling and analysis. So moving on to the notification process. A prepayment notification letter is sent to the provider to inform them that they have been selected for the prepayment review. And then all the phone calls come streaming into your office. Angry providers, what is going on? it happens. As nice as the letter is and as clear-cut as it is, they're going to have questions. So the provider will receive an explanation as to why they were placed on the review and a description of the review process. Commonly, they'll be given the time frame for the receipt of records and what will happen to the claim. For example, denial if the records are not received in the time allowed. They will be given an explanation of the payer's specific appeal process, including timeframes, and a specific list of supporting documentation that they will need to submit with the claims that are subject to the prepayment review, as well as a description of specific claims subject to the review. Post-notification steps for prepayment. Claim submission triggers the review. When the provider submits a claim that is within the scope of the prepay audit, the claim will pend due to a claim processing edit. The next step will be record receipt verification. An assigned auditor will confirm receipt of the corresponding records. If no record is received, the claim will pend, and after the client designated period of time has ran out, the claim will eventually deny. If the record is received, we're going to move on to the audit. So the auditor will review the documentation in accordance with the audit focus. For example, if the audit focus is evaluation and management, high-level E&Ms, the auditor will utilize the documentation guidelines, CPT rules to determine the code level supported by the documentation. In the case of a modifier audit, the auditor will review the documentation to determine if the documentation supports the modifiers applied, utilizing CPT and NCCI edits. The next step in a prepayment process is the result. The audit result is communicated real time. Excuse me. So the result would be data entered into the claim processing system. And if the code is supported by the documentation, the claim will release and pay. If the code is not supported, the claim is adjudicated to deny. And the next step would be provider action. If the claim is denied, providers may choose to review their claim and submit a corrected claim form. Providers should consider the result of their paid or denied claim to determine if there are educational areas identified for internal staff, coding departments, and billing office. And same as post-payment review, basically anything can be reviewed in an audit. Anything that you would like to do data analytics and take a look at. But there are some common areas that are often good for prepay reviews, and that would be high-level E&M services, like level 4s and 5s, unbundling modifiers, such as modifier 24, 25, and 59, as well as some of the surgical modifiers like 22, 58, 78, and 79, and there's many other options too. To go into some detail about what a modifier 22 audit would look like. So modifier 22 is appended to claims, to a surgery claim. The provider is using that modifier to indicate that it was substantially greater than what would typically be expected. So, for example, a lot of times this happens with abdominal surgeries, and the surgeon will encounter extensive adhesions, which requires a significant amount of lysis, surgical cutting away of those adhesions. And so lysis of adhesions billed with an abdominal surgery is a bundled claim. So those two CPT codes would not pay together. And often providers, complain about that because, well, it took me like 3 hours to cut through all of the scar tissue and all of the adhesions before I could even complete the abdominal surgery that I needed to do, to begin with. So why can't I get paid for it? So they often will apply modifier 22 to a claim like that because it was greater than typically expected. And modifier 22 is supposed to enhance the fee. It's the plan's policy whether they do enhance the fee or not. But this is often a prepayment review item because since they are enhancing the fee, they want to probably verify, the plan wants to verify that it's supported by the documentation or supported in the documentation. So this is a modifier. When reviewed, it will or it may provide a financial impact because, again, modifier 22 would enhance the reimbursement. Modifier 24 for prepayment audit. Modifier 24 is applied to unrelated E&M visits that are provided during the postoperative period. Surgeons will apply modifier 24 to unrelated visits which occur within a 90-day global surgery period. So most, major surgeries have 90-day follow-up periods, and the surgeon who performed that major surgery, everything that's related to that surgery is not billable during that 90-day period. There are some certain situations that are payable. For example, if they have to go back to the operating room, they can use a modifier to say that they had to return to the operating room during the postoperative period, and that's acceptable. But applying modifier 24 to visits that are for a postoperative complication, according to CMS rules, is unacceptable. And there's other instances where you'll see this modifier 24 used. So prepayment review is a good option for this modifier. It will determine coding errors real time, and it may have a financial impact because errors are found from unbundling. Another focus for prepayment reviews is modifier 58, 78, and 79, and these are surgical related modifiers. These modifiers cause a lot of confusion. Modifier 58 is a staged or related procedure or service by the same physician during the postoperative period. Modifier 78 is an unplanned return to the operating room or procedure room by the same physician following initial procedure for a related procedure during the postoperative period. And modifier 79 is an unrelated procedure or service by the same physician during the postoperative period. So these three modifiers are similar in a lot of ways, but different, and they all have different uses. And coders and providers often get confused on which modifier to use in which situation. So these are good modifiers for prepayment review in that it provides immediate provider education. But the education will lead often to providers submitting corrected claims. Therefore, this audit likely will not afford a significant financial impact for the carrier or the client. Instead, it will yield an educational opportunity. So this is an awesome audit that is merely educational, because often you will find that the claim was performed and a modifier was warranted, but maybe they just built the wrong modifier. So you would see here that there's minimal provider abrasion. In summary, how do plans determine when to release a provider from prepayment review? The standard of evaluation to determine when a provider's claims will no longer be subject to the prepayment review is based on the error rate. And that error rate is defined by the plan. So maybe the plan wants to see the provider's error rate, below 20%, below 15%. That is a number determined by the plan or by the client. Who else gets involved in these audits? So a lot of times, especially with prepayment reviews, The other parties that are involved would be like plan network specialists. They may have to reach out to providers. Some plans may offer copying services where the network specialist will go on site and copy the records or scan them for them. So there are some other people involved. And reporting. Any type of reporting could be created to capture what the client is looking for. Often reporting in prepayment review looks at and gauges how well the provider is improving. So when they've been in the prepayment audit for a number of months, have they learned anything from this experience? Has their coding patterns changed? And at what rate? So in contrast and comparison, pre- and post-payment reviews, post-payment audits, post-payment recovery expenses can account up to 20% of the actual collections. Investigators and audit firms must keep an eye on ROI. Post-payment recoveries can take as long as 24 months. Audit recoveries, audit activities, and payment recoveries may hit roadblocks, delaying the recovery process. 24 months is probably an average, if something like a really bad average for a delayed post-payment type process. But there are instances that could delay the process. If it's something that's being extrapolated, it may go to litigation. If there is a fraud referral, maybe if something is referred to the OIG, that could halt everything for a period of time until that's investigated. And post-payment review can have a negative impact on provider relations because the perception is that you're taking back their money when trying to recover overpayments. Providers often feel this is a personal attack. Another contrast and comparison, post-payment recoupment may be necessary in complex cases when payers must honor prompt pay regulations while collecting information that may reveal an overpayment. And in many cases, an effective audit and recovery program can offer insights into overpayments with root cause analysis and process improvement recommendations to help prevent claims errors from reoccurring in the future. So if the plan has an agreement that they made with a provider about prompt payment, they may not be able to perform this prepayment review. So post-payment would be the option. Post-payment compared to prepayment. Post-payment, we have delayed response to risk results in costly pay and chase scenarios. Prepayment prevents payers from payment of suspicious or potentially fraudulent claims. Post-payment requires stable and complete data. And in the prepayment environment, the risk is accurately analyzed even when the data is incomplete. Post-payment recovery is justified only when there is a large financial impact. Prepayment action of non-payment is cost justified even for small instances of fraud, waste and abuse, and error, which becomes significant if allowed to accumulate. In post-payment, post-payment can result in legal proceedings, and prepayment shapes provider billing behavior proactively and reduces the need for legal proceedings. Prepayment review of claims requires no extrapolation of claims data, which is a good thing for states that do no extrapolation. And plans seeking to become industry leaders continue to intensify efforts aimed at identifying overpayments before claims are paid. The value of this approach cannot be understated, with advantages ranging from diminished provider abrasion, avoidance of costly pay and chase methods, and reduced administrative work. Common documentation errors discovered under the Medicare Part B services include, again, these are the same that I went over earlier: insufficient documentation of procedure service, missing or illegible documentation and physician signature, as well as incorrect coding errors. So in comparison, in contrast, at the same time, most health plans are continuing to invest efforts to prevent overpayments, knowing the money they will save by identifying erroneous claims early strengthens their bottom line. A full-featured strategy that includes claim scoring, predictive analytics, and rules-based detection technologies is vital for today's health plans. So I know I talked really fast today, and I apologize. We're going to give you guys these slides if we haven't already. So if I went too fast, you can go back through and look at them in detail. But we can turn it over to questions and best practices.
Thank you, Melissa, for that informative presentation. We're now going to go over some questions. If you have any questions, please send them to all organizers in the text box. So our first question that we received is, what is the best practice for auditors getting ready to start a new audit or work with a new client? Melissa?
Oh, I'm sorry. I apologize. Can you hear me?
Yes.
Okay. Thank you. So the best practice would be getting prepared for the audit, getting to know the client, what their needs are, what the scope is, learning the regulations that will pertain to the audit focus, getting to know the state regulations, if there's a federal consideration of regulations, and plan specific. So doing your research is so important.
Great, thank you. Our next question is, do you have a recommendation for post-pay sample sizes?
Sample sizes vary, and it's best determined by a statistician or using rat stats. It's really important if you are extrapolating to have this done, by a statistician or using rat stats, because a legal defense will try to discredit the validity of the sample.
Our next question is, are there any other audit types not discussed here today?
Sure, there's many kinds of audits. I went over the two major types. Another type of audit that we only touched on very briefly in this presentation today was self-audit. CMS mandates, as part of the compliance process for providers, that they should do self-audits. So that would be providers taking a look at their claims internally, and they can choose whether they're going to do that before they bill or after they've billed for the claims. But having a certified coder go in and review the records, just like an auditor would, but doing it internally and seeing what you find. There's a lot of responsibility involved in doing a self-audit, being that when a provider does a self-audit, when they identify areas that need to be corrected, they need to take that corrective action and document, what was done. Especially if the claim was already billed. If the claim was already billed, they have a responsibility to notify the claim, or to notify the carrier of the errors.
Thank you. The next question that we got is, what is the best practice for a situation where the provider realizes they have made errors? Submit the documents or don't submit the documentation with the understanding payments will be recovered?
Oh, that's a great question. Thank you. I would suggest that providers, when they're in an audit situation, always submit the records, because the record, without submitting the record, it'll be a full claim error. Always, if there was an error, so say the claim should have never been billed, and when the provider reviews the claim, the record, and makes that determination that it was a complete error, that they shouldn't have billed the claim, you will need to notify the carrier. Outside of your audit, you'll need to make a notification to the carrier, and that can be done through a corrected claim, where you state that the claim was billed in error, or through an appeal process, depending on the process that the carrier has set up. But also you can send with the record a letter to the auditor stating that you noticed that there was an error.
Great, thank you. The last question that we have is comes from someone. They said, I'm not sure if this is relevant, but is anyone else having a problem with 78452-26 denying for POS 19 with Medicare? Also, other carriers are denying services billed as POS 19.
That's a good question. And Brittany, I'm going to have to do some investigating to look that up. So off the top of my head, the question is pertaining to a radiological procedure with Modifier 26, which is the professional service. Place of service 19, I'm not thinking off the top of my head what place of service that is. So if we could respond in an email following, I could definitely give you some information about that.
Of course. Someone just put in the text box that they said, I think POD 19 is unassigned. That's another call that we just received.
Okay.
But we can send out the answer to that question along with the email after the webinar. But for now, that's all the questions we have. If anyone has any further questions, feel free to email Melissa or reach out to any of us, and we'll direct your questions to her. And thank you all for attending today's Advize Health webinar on prepayment and postpayment reviews. We will be sending out an email including a certificate of the completion showing 1.5 CEUs earned, a copy of the presentation, and a recording of the webinar within 2 to 3 business days. And be sure to be on the lookout for our next webinar on meaningful use and risk analysis that will be held in March. So look out for that. Thank you all and have a great rest of your day.
Thank you.